Bismillahirrahmanirrahim. Assalamu alaikum, everyone. My name is Dr. Tejhmal. Thank you very much for attending this second parallel session. Firstly, could I kindly request our chair persons to kindly come on the stage? I would like to request Professor Abdul Basit. Professor Abdul Basit is the director of Bakai Institute of Diabetology and Endocrinology, Chair-elect IDF MENA region, Joint Secretary Diabetic Association of Pakistan, and a founding member of Pakistan Endocrine Society. Thank you very much, Professor Abdul Basit. And the second chairperson I would like to request is Associate Professor Fawad Ahmad Rhandawa, who is Associate Professor at King Edward University Hospital. Thank you. So in this session, which we have entitled as Mixed Bag, we have got three excellent speakers to talk about their areas of expertise. We have two virtual talks from the UK and one face-to-face talk. So the first speaker for the session is a good friend of mine. We trained together in London, Dr. Guiseppe Maltese. Dr. Guiseppe Maltese is a consultant physician in diabetes and endocrinology at Epsom and St. Helier's Hospital and a honorary clinical lecturer at King's College London. He graduated with a distinction in medicine from the University of Messina. Having trained in general and geriatric medicine as well, he has a special interest in the management of frailty in diabetes. During his PhD at Cincinnati Children's Hospital Medical Center, Cincinnati, Ohio, USA, and during his specialty training at Guy's and St.Thomas Hospital, he studied biomarkers of aging in diabetes, cardiovascular, and renal disease, and he has authored numerous publications in reviewed journals. His current clinical and research work focuses on the impact of multi-morbidity and frailty on diabetes-related outcomes and the use of technology in older people with diabetes. He has been the lead author of the Italian version of the NHS document, and as a fellow of Higher Education Academy, Dr. Maltese is actively involved in the teaching and supervision. In 2021, he was appointed as one of the top 20 UK clinical champions with a project aimed to improve diabetes care in long-term facilities. Dr. Maltese will share his expertise on the topic of endocrinology of aging.
Good afternoon, I'm Giuseppe Maltese. I'm a specialist in diabetes endocrinology and geriatrics at Epsom and St. Helier University Hospitals in London. I would like to thank the Pakistan Endocrine Society conference organizing committee for inviting me and for giving me the opportunity to talk on this topic. So I'm going to describe today the age-related changes of the hypothalamic pituitary axis, and I will provide the current evidence on hormone replacement strategies. With aging, the secretory hormones patterns of the hypothalamic pituitary axis change, as does the pituitary axis sensitivity to the negative feedback by end hormones. As you can see, the majority of the hypothalamic pituitary axis hormones decline with aging. The only exception is the hypothalamic pituitary adrenal axis, which is overactive in terms of cortisol production. Let's start from describing the thyrotropic axis changes. There have been a few studies showing an elevation of TSH with aging. This is a study published in 2002, including participants from the National Health and Nutrition Examination Survey. What the authors found was an age-related increase in TSH in the general population, both in men and in women. They also found, data have not been shown, a rise, age-related rise in anti-TPO and anti-thyroglobulin antibodies. So what's the meaning of the clinical significance of this elevation in TSH? There have been numerous hypotheses. So the TSH elevation can be expression of a decline in thyroid function or a reset in the TSH set point. This was a nice work done by Nir Barzilai and his collaborators in the States. What they analyzed, they analyzed the TSH and free T4 concentrations and frequency distribution curves of TSH in Ashkenazi centenarians, people with an exceptional longevity, median age 98. These people were thyroid disease free, and they compared the levels with Ashkenazi controls, median age 72, and controls from NANES study. And what they found was that the concentrations of TSH were higher in centenarians compared to controls. As you can see, the distribution curves were quite similar, but the TSH distribution in the centenarians was shifted significantly to higher serum concentrations when compared to Ashkenazi and NANES control groups. So we could speculate that this elevation in TSH with aging could be a kind of adaptive mechanism, a phenotype of longevity. So there has always been concern around thyroid dysfunction and mortality. In this retrospective study, they analyzed the all-cause mortality, the risk for MACE and myocardial infarction in people with subclinical and overt hyperthyroidism and people with subclinical and overt hypothyroidism. And they found an increased all-cause mortality risk for MACE in individuals with subclinical and overt hyperthyroidism. Interestingly, the all-cause mortalities was lower in individuals with subclinical hypothyroidism. There was a positive association between subclinical hypothyroidism grade 2, means TSH above 10, and risk of myocardial infarction. And what's the evidence around subclinical thyroid dysfunction, subclinical hypothyroidism, and cognition? This was a very large multi-cohort study involving nearly 75,000 patients. They assessed cross-sectional and longitudinal association between again subclinical and overt hyperthyroidism and subclinical hypo and subclinical and overt hypothyroidism and cognition. No significant associations were found with any between any degree of any type of cognitive dysfunction and global cognition, executive function, and memory. What's the evidence around levothyroxine replacement in people with a subclinical hypothyroidism? This was a trial, randomized clinical trial, placebo-controlled, and they randomized people to either placebo or levothyroxine replacement. These were older people with subclinical hypothyroidism. After 12 months after achieving the euthyroidism, the cognitive function was not better when compared to placebo. In this other clinical trial, the levothyroxine replacement did not have any did not provide any benefits in terms of hypothyroid-related symptoms, and did not have any positive impact on secondary outcomes, including quality of life, executive cognitive function, blood pressure, weight, BMI, measures of physical performance, fatal and non-fatal cardiovascular events. So if the thyrotropic axis is underperforming, the hypothalamic pituitary adrenal axis is overactive. This is what has been shown in rodents. So with aging, there is a reduction in type 1 mineralocorticoid and type 2 glucocorticoid receptors, leading to an inhibition of the paraventricular nucleus, which results in attenuated glucocorticoid-mediated negative feedback, which results in increased CRF, increased ACTH, and finally cortisol. So based on this background, the increased activation of the hypothalamic pituitary adrenal axis is the main responsible for the increased 24-hour total and free plasma cortisol, increased daily cortisol secretion, increased corticosteroid production rate, the earlier morning cortisol peak, and the decreased amplitude of the 24-hour cortisol secretion with a flattened cortisol profile. No changes in cortisol binding globulin have ever been detected. What is interesting is that the post-dexamethasone cortisol levels in older people are higher when compared to young people. Urinary free cortisol is unchanged, probably because of age-related renal dysfunction. Some of the changes occurring with aging are very similar to those which can be observed in people with hypercortisolemia, and it is thought that the dysfunction of the hypothalamic pituitary adrenal axis can contribute to some age-related diseases like dementia, coronary artery disease, or sarcopenia, or depression. This is a study published about 10 years ago. They demonstrated how the diurnal cortisol patterns correlate with the physical performance. Middle-aged men, 45, 59 years, were at the follow-up for 20 years. Outcome measures were walking speed and balance time. Exposures included morning fasting serum cortisol in the phase 1 and 4 salivary samples on 2 consecutive days in the phase 5. What the scientists found was that faster walking speed was associated with higher morning cortisol in the phase 1, but higher nighttime cortisol was associated with lower speed in the phase 5. The worst performance was seen for men with a poor morning response and less nocturnal decline in the later stage of life. And this is a further evidence that dysfunction of the axis can accelerate age aging and can contribute to frailty. This work, Linda Fried and her collaborators showed a correlation between the evening cortisol levels and the severity of frailty in frail older women. Aging has an impact on the adrenal steroid hormones as well. The pregnenolone synthesis decreases because of the reduced lipid intake into the mitochondria. As a consequence, there is a reduced concentration of the DHEA and its sulfate form. So there is no clarity about the clinical significance of low DHA. Low DHA levels have been associated again with disability and frailty. And the replacement is not data around the replacement have been quite conflicting. What happens to the somatotropic axis with aging? Aging is associated with a decay in the somatotrope axis due to a progressive decline in growth hormone. The growth hormone starts declining after puberty and continues to drop during adult life and aging. The concentrations of IGF-1 levels are in older people are lower than in young adults. Physiological changes occurring during aging are very much similar to those which are observed in somatopause, and including increased fat mass, increased cardiovascular risk, reduced muscle mass, reduced exercise tolerance, and decreased strength and impaired quality of life. There is a strong evidence that the growth hormone replacement can exert beneficial effects on muscle mass, total body fat, improves sleep and improves the cognition. There are no effects on HDL, LDL, and triglycerides. There is no much evidence around bone mass, functional capacity, and glucose metabolism. There are several side effects, including fluid retention, carpal tunnel syndrome, gynecomastia, and increased risk of cancer. So the similarity between aging and growth hormone deficiency, the improvement of growth hormone deficiency symptoms with treatment, and the fact that elderly people have an impaired growth hormone IGF-1 signaling have raised the question whether treat or not older people. This is a meta-analysis of 18 clinical trials published about a few years ago, and the conclusions were that growth hormone replacement in healthy older people have only are associated with minor benefits, and at cost of several important side effects like soft tissue edema, arthralgia, gynecomastia, and carpal tunnel syndrome. So at present, the growth hormone replacement is recommended only for people with hypopituitarism, a growth hormone deficiency. So we move now to the aging of the female reproductive system, which is driven by a depletion of the cohort of primordial follicles and the lower quality of the oocyte, with a decreased fertility from the fourth decade onwards. The decreasing size of the antral follicle is responsible for the changes in the hormonal feedback with a reduction in inhibin B in the early stages and inhibin A and reduction in estradiol in the later stages. These are the clinical consequences of the hormonal changes: hot flashes, bone loss, vaginal dryness, and urinary symptoms. HRT, hormone estrogen replacement therapy, is of benefit because it improves the symptoms, improves the quality of life. Unfortunately, only a minority of post-menopausal women use HRT because of the fear of HRT-related risk. However, there is now evidence that there is a number of factors influencing the benefits risk profile, like age, years of from menopause. It is recommended, in fact, that HRT is started before the age of 60 and within 10 years from the menopause. The type of HRT is dictates the type of risk. In fact, the transdermal estrogen is associated with a lower risk of venous thromboembolism, of cholecystitis, of breast cancer compared to an oral estrogen. The mode of delivery is important as well, but we have to keep in mind that the duration has a huge impact. In fact, a duration longer than 5 years, an HRT duration longer than 5 years, is associated with a higher risk of breast cancer. These are the two studies confirming what I said. The first one was published in the BMJ, and they concluded that the levels of risk varied between types of HRT. In fact, the highest risk was found with the highest risk of breast cancer was found with noretisterone, and the lowest risk was found with dihydrogesterone. And also, women with a HRT duration longer than 5 years were at higher risk of breast cancer. In this other study published in JAMA, the risk of in women with estrogens plus medroxyprogesterone for a median of 5.5 years, or just estrogens for a median of 7.2 years, the HRT was not associated with a risk of all-cause cardiovascular or cancer mortality during a period of 18 years. Slightly different story with the male reproductive system. In fact, men do not undergo something similar to a menopause. However, there are some changes related to aging. There is a reduction in testicular volume by 30%. There is a number of Sertoli cells reflected by an increase in FSH and decrease in ratio serum inhibin FSH. In terms of sperm, there is a reduction in the ejaculate volume and a deterioration in spermatozoa motility and changes in morphology. The total and serum dihydrotestosterone decrease. What are the causes of what happens to the total testosterone? The total testosterone decreases by 25% between the age of 25 and the age of 75. The sex hormone binding globulin increased by 1% per year. This implicates that the the testosterone, which is not bound to sex hormone binding globulin, drops drastically by 50% between the age of 25 and the age of 75. What are the causes of low, free, and total testosterone? Increase in LH and FSH concentrations, reduction in testosterone response to LH and chorionic gonadotropin, and reduction in Leydig cells. The symptoms associated with low testosterone are well known: reduction in sexual desire, reduction in muscle mass, reduced bone mineral density, and increased risk of osteoporotic fractures. There is evidence that the cutoff for the occurrence of symptoms of low testosterone are less than 11 nanomole per liter for the total testosterone and less than 220 nanomole per liter for the free testosterone. Among the small trials on testosterone, the testosterone trials represent a set of well-coordinated trials showing the effects of testosterone replacement in older people, hypogonadal people. The benefits are well demonstrated. Testosterone replacement can improve the sexual activity, the sexual desire, and the erectile dysfunction, can increase the sexual thoughts, the attentiveness to erotic cues, can increase the duration and frequency of nocturnal penile erections, and can increase the ejaculate volume. It has been also demonstrated that they can increase the muscle mass and the performance on a number of physical performance tests. So it is recommended that the approach to testosterone therapy in older people is individualized. 3 steps should be followed. First of all, it is important to establish the evidence of low testosterone. Second, it's important to weigh the burden of symptoms and signs against the benefits and risk of long-term treatment. And 3, it is very important to identify those patients who may be at risk of long-term harm, like people with erythrocytosis or people at risk of prostate cancer. There is not much evidence around testosterone, or we can say that there is conflicting evidence around the link between testosterone and cardiovascular mortality. As a number of studies have shown an increased mortality in people who are treated with testosterone. We will have to wait for the findings of the Traverse trial, which is a trial evaluating the impact of testosterone replacement on males in people aged between 45 and 89. In conclusion, age-related modifications in the endocrine system should be taken into consideration when it is time to interpret hormone concentrations in older people with and without endocrine disorders. Some of these changes, as we said, may represent a beneficial adaptation to aging. Hormonal replacement is not always the answer. It does not always provide clinical benefits, and in some cases can be associated with significant adverse events. Age-specific hormone reference ranges could help to avoid misclassifying and overtreating older people. Thank you for your attention. I'm ready to answer any question. Thank you.
Thank you very much, Dr. Maltese. He's live and we can take questions.
Yeah, hi. Thank you for a very interesting talk, Dr. Maltese. I really enjoyed that. This is Dr. Khadija Irfan from Lahore, and I'm an endocrinologist. And I was very interested in what is your take when you showed the relative risk for mortality with the thyroid illnesses. And while severe hypothyroidism was associated with an increased risk for myocardial infarctions, I'm very interested that how subclinical hypothyroidism was seemed to be protective and was showed a reduced mortality risk. So how do you explain that rather surprising finding?
Oh, hi, good afternoon. Thank you for your question. So indeed, the current evidence reflects my clinical practice. I'm usually quite conservative with older people when the TSH is just mildly elevated. If you ask me about the mechanism behind this protection, indeed there is no much evidence there. As I showed you that study from Barzilai demonstrating that centenarians, this model of longevity, human model of longevity, present slightly high TSH levels. So there is no much evidence around the mechanism. About the association TSH higher than 10 and increased myocardial infarction, I suppose we can link the increased TSH with an altered lipid metabolism, which can favor, maybe represent a risk factor for ischemic heart disease. So yeah, again, some mechanisms have to be elucidated.
Okay, thank you. Any more questions, please?
Can
yes, there is one more question.
Dr. Maltese, thank you for your talk. I'm Abdul Basit. My simple question is, can you suggest then any intervention which can delay aging, which we would all like to have? Any endocrine intervention that can delay aging?
So I have a recommendation. It's a non-drug recommendation. Mediterranean diet, exercise, and a large amount of broccoli containing sulforaphane, which we have demonstrated increasing a novel hormone called cloto. We will talk about cloto next time.
Thank you.
You're welcome. Okay.
Thank you very much, Dr. Maltese. It was wonderful to listen to your excellent talk, and thank you for joining us live on Saturday morning. And we will close it here. Thank you so much, Giuseppe. Bye-bye.
Thank you, Dr. Rehman. Thank you, everyone, for inviting me. Thank you. Bye.
Our next speaker is Dr. Dulmini Karyawasam. Dr. Dulmini Karyawasam was appointed as a consultant in 2005 and is the clinical lead for transition and young adults diabetes and endocrinology services at Guy's and St.Thomas Hospital, London. And during this time, she has led on many changes in the way care is provided. Young Adult Clinic has won many national awards, including Quality in Care Award in 2016 for the YES project and National Positive Practice in Mental Health Award in 2014 in recognition of innovative multidisciplinary working. She has been instrumental in developing an innovative program for young adults with diabetes, and this project has been funded by the local CCGs. She was awarded an awards lecture at Association of British Clinical Diabetologists at their national meeting in 2014 in recognition of leadership and considerable originality in thinking on the development of above services. Her team won the Health Service Journal Best Diabetes Care Initiative in 2020 for the YES program and the Best Transition Model of the Care at the National Diabetes Transition Work. She was a member of the group that analyzed type 2 diabetes problems in adolescents and young adults. Her other research interests include hypoglycemia and hypoglycemia unawareness, and intervention to address this high-risk population. Dr. Karyawasam is kindly going to share her experience and expertise on a topic entitled Transitional Diabetes Care, Do's and Don'ts. Thank you.
Hello, everybody. My name is Dr. Dulmini Karyawasam. I'm the lead for the Transition and Young Adult Diabetes and Endocrine Services at Guiseppe St. Thomas Hospital in London. So thank you very much for inviting me to talk on the title Do's and Don'ts of Setting Up a Transition and Young Person Service. I would like to share our experiences at Guiseppe St. Thomas, and which has one of the largest young adult services in the UK. I will discuss some principles that is hopefully transferable and adaptable to the service you have. So I have nothing to disclose. We know most young people with type 1 diabetes is diagnosed before the age of puberty. Life expectancy for children diagnosed before the 10 years of age is 16 years shorter than somebody without diabetes. But not only that, it's 10 years shorter than somebody diagnosed after puberty. Now, this is data from the Type 1 Exchange Registry. As you can see, there's a significant deterioration in glycemic control between the ages of 15 to 25. But what is more worrying is if you look at the two lines, 2010 to 2012 is in green, red, and 16 to 18 is in blue. And you can see during this time period, the problem is getting worse. And this is despite using much more technology and with more newer insulins being available. Now, there are many reasons for this deterioration. Psychological changes that happen during puberty, which we'll talk about later, and also gaining independence from the primary caregiver, beginning to take more control of their diabetes management, peer influences, social issues like starting work, going to university, or starting a family. I suppose these changes are universal for children at this age, irrespective of where and which country they live in. So the first question to answer, I suppose, is do you need a specific young adult transition service? Now, to understand or answer that question, let's look at how teenagers make decisions. This is the teenage brain, and you can see the areas in purple and blue are the areas that's fully developed, whereas the red and yellow areas are underdeveloped. And you can see for the frontal lobe, which deals with executive functions such as weighing up long-term consequences, controlling impulses, is the last to mature. In fact, it takes about mid-20s for the frontal lobe to mature fully. So how do teenagers make decisions then if their frontal lobe is immature? Now, let's see what would happen if you give them a reward. Let's say money. Teenagers like money, or sugar. See what happens to their brain through functional imaging. And you can see this is a cross-section of the ventral striatum, which is the reward processing area. You can see there's a huge difference between children and adults. A teenager's frontal brain activation, ventral striatum activation is much more than in an adult and a child. Therefore, adolescents get really excited about reward, appetite, pleasure sensations, and new experiences. Now, you may have seen some of this data from this research. So this study got young people and adults to drive a car in a simulator and counted the number of crashes they had, and then they told them that their peers are observing them. And you can see what happens. So when the moment young adults or the adolescents are told their peers are watching them, the number of crashes go up. Whereas in young adults and the adults, the complete opposite happens. So young people are more susceptible to peer influences and pressure, and they're more likely to take risk-taking behavior and experimentation. So what I'm trying to explain is young people's decision-making is different than that of adults. They're more in present, peer context, and context and influences can make and change how young people make decisions. Now, there are many physiological changes that happen during puberty and growth. There's significant increase in peripheral insulin resistance, and you can see the fasting insulin rate can double or treble during puberty and adolescent phase, even in people without diabetes. Now, this is due to an increase in IGF-1 levels and increased fatty acid oxidation. High levels of growth hormone during the growth spurts make them more likely to go into ketosis. These are average insulin doses you need at different phases of life as a child. And you can see an adolescent will need somewhere between 1 to 1.5 units per kilogram per day of insulin. If you think these are the insulin levels that a type 2 obese patient would need, but these are the insulin adolescent with type 1 diabetes would need. And the most insulin resistance and the highest insulin doses are needed in Tanner stage 3 or 4. And at the same time, diabetes will also have an effect on growth. Timing of the growth spurt will be influenced by the glycemic control. And poor control can delay growth and cause stunted growth. And if you have teenage children, you're probably familiar with this concept. They need a lot of calories. They eat a lot because they're growing and they need a lot of calories. All these things will affect their diabetes control. So I would say the time it is most difficult to have diabetes because you're young, you're growing up, your social conditions, psychological conditions are changing quite rapidly, is the time diabetes is most difficult to control. So I would argue these young people can't be in a pediatric clinic or your standard adult clinic. Young people need a specific dedicated young person's service. So when you're setting up a new service, what are the principles? What things do you need to consider? Number one, you need to understand the population you serve. Now that might sound quite obvious, but you need to have an idea of the number of patients in your locality and the percentage of type 1 and type 2 prevalence and other socioeconomic factors at play. From my point of view, as a specialist, you cannot be only responsible for the patients who come to see you in clinic, because the ones who don't are the highest risk patients that will enter healthcare systems later in life with complications. So if you see here a map where we've plotted all the patients that come to our clinic, and you can see they're mostly from our local area where the hospital is situated, but they come from a very far afield as well. Now, number two, pediatric and adult colleagues need to collaborate and work together. If you're working in your silos where pediatricians work separately and the adult diabetologists work separately, there is evidence that pediatricians will be late to transition. One of the reasons is due to this emotional attachment. Number two, they don't really believe that the patients will get the same level of care when they go to a busy adult clinic. Young people will also be reluctant to transition if they think they're going to go into a standard adult clinic, and that will delay the transition age. And that is with repercussions. So developing a transition model together is really important, and tracking and monitoring progress of your patients and sharing that data with the pediatric colleagues is also really important. So this is the transition model we have here at Guy's and St. Thomas's. We start the transition process when they're about 12 years of age, and we let the young person and the family know about the pathway. And then we start doing joint clinics. So the pediatric team and the adult team will sit in the same space and do a clinic together where the young people would come. And then they would come to a young person's clinic, which is held in the adult side of the hospital. And they will be in this dedicated young person's clinic till the age of 25. And it's really important to understand that both these clinics are done by the same group of healthcare professionals providing continuity. And when they're 25, they will go to our dedicated type 1 adult clinic or type 2 adult clinics. Now, if you, in the UK, we have something called the best practice tariff, which is a tariff for providing optimum pediatric diabetes care, and they recommend that transitions should be after 18 years of age, whereas the American Academy of Pediatrics recommend that the transitions should start at 14 years of age. Now, there's no magic number. You need to understand your population and understand what the best age to transfer the care from the pediatric to the adult team is. So for us, we decided that it would be 16, and hence our transition pathway. Working together will bring another dimension to the service, increase in patients' autonomy, because if the adult physicians are involved, they will be more interested in speaking to the patients as opposed to the patients and caregiver. And what do young people expect from a good young adult service? They want the doctors and nurses to earn their confidence. They want them to listen carefully and also involve them in the management decisions rather than being told what to do, and at the same time being understanding of the difficulties that they have to face as teenagers managing diabetes. You'd work in an MDT, and whole MDT should have a clearly defined roles and work towards a common name and a common goal, and also ensure that you have the necessary competencies and skill mix within your multidisciplinary team. Now, this is cartoon of the skill set that you would need when you're doing young adult diabetes clinic. And I've specifically put the clinical engagement on the left of this column, because I feel like that's the most important skill that you need to have. Good communication skill, motivational interviewing skills, CBT, care planning, and then adolescent health, understanding how development and biological physiology, how adolescents are different, and then understanding roles and responsibilities of a caring adult. How would the parents feel during this time is really important. And you need to have a specific skill set, how to use insulin, how to use technology, the eating behaviors. For us, it's becoming a common problem that young people are developing more eating disorders, and their risk-taking behavior, contraception. And also being able to use technology is really important when you're doing young adult clinics. Now, that's about using technology like pumps, hybrid closed loops, sensors, but in addition to that, using things like Twitter or YouTube or TikTok for education and engagement. Now, the service cannot depend on one individual. It's really important as a specialist, you upskill the team around you. You have standardized approaches, a well-defined pathways. And there is also evidence, if you look at the best young adult clinics in the world, that the clinics that have standardization and each healthcare professional gives the same message to the young persons, whether it will be about HbA1c targets, blood glucose targets, how to manage exercise, those clinics are shown to have better outcomes. So having a same approach, common approach across the pathway by each care member is really important. So this is our multidisciplinary team. So this is the team that would do the young person's clinic. There are doctors, there are specialist nurses, there's dietitians, psychologists, psychiatrists. We have a youth worker who would work with them in the community, and we have the admin teams. And the young person's clinic is a secure base where young people can come and safely share their experience and feel that they're heard. And it's really important we meet together as a multidisciplinary team. We have a non-hierarchical way of conducting these clinics. So the youth workers' voice is heard as equally heard as a consultant's voice. And we run virtual clinics to review our database, joint meetings with PEDS team, and also a risk register, reviewing the highest risk patients. Now, you can't stress the importance of educating young people and patients with type 1 diabetes to self-manage their diabetes. So if you look at the Diabetes website in Rotterdam, one of the best young adult transition services in the world, they emphasize how important education is. Activated, well-informed patients is needed, essential for good clinical service. If you look at the type 1 exchange registry, it looks like we're not very good at discussing things that matter to young people. For example, we discuss 50% of the time we would discuss about alcohol and only 1/3 of the time about reproductive health. So what is really important to understand is transition is not about just transitioning a person from a pediatric clinic to an adult clinic, but it's about transitioning them from a dependent child who's been looked after by the parents to an adult who's independent, self-empowered, and self-managing. And as healthcare professionals, we have a duty to help them transition through knowledge and self-management as well. So for diabetes, the focus on education would be on carb counting, self-adjustment of insulin doses, and self-management, exercise, diet specifically. For type 2 patients, we do some cooking classes for teenagers on healthy diet options and some exercise sessions. So those are important. Sexual health, driving, smoking, alcohol, contraception, going away, going to university, teaching them about the social factors that would affect their diabetes. And then sick day management and hypoglycemia management. And more importantly, care navigation. How would they book an appointment? How would they collect their prescriptions? Where would they get their medicine from? So those things are really important. So we here at GSTT run a course called the Youth Empowerment Skills course, which is run over 3 days, providing some of the education that I've talked about over a 3-day period. Now, this probably is one of the most important factors in your young person transition service. Establishing relationships. How do you keep a young person engaged when the HbA1c is not good? How do you make sure you do not lose that patient? So a balance between HbA1c and engagement. There is really good evidence if you look at the literature that a strong relationship with the healthcare professional will predict good outcomes in the long term. So invest your time on getting to know the young person, but not just looking at the numbers or the blood pressure or the download. Developing that relationship, understanding the patient will help you in the long term to improve their outcomes. Use young people in the service development, develop a service around them. And for us, the young person's clinic, that's the time they do their GCSEs and advanced level exams. So we run late clinics. We start clinics at about 3:30 p.m. and run them till about 7 o'clock so that kids can come to the clinic after missing school. Because there's no point in blaming young people for not coming to clinics or missing appointments. So design the service not around what suits the healthcare professionals, but what young people need. It's so important to review data regularly. Understand what needs changing, where the gaps are in your skills, and don't be scared to try new things. Try to do things in a different way, and benchmark your service with the best in the country and then also internationally. So in summary, this is our young adult clinic model here at Guiseppe St.Thomas's, and you can see engagement, as I said before, plays a major role. We put a lot of emphasis on making sure patients are engaged with the service. We have a dedicated, upskilled, dedicated young persons team. Interventions such as pump technology, exercise, and education programs. and then a continuous review of data and continuous iterations to get the clinic running better happens continuously. So these are some of our young people having completed the YES program. And you can see our young people come from a variety of ethnicities, variety of psychosocial backgrounds. So we have to develop a service that would suit all these young people. So thank you very much for listening. And I hope that some of the basic principles will be adapted to your services when you're delivering young people's care. And thank you so much. And I'd be very happy to take any questions if you have.
Dr. Karyawasam is live and happy to take any questions. I think this is really thought-provoking talk for all of us who do encounter young adults with diabetes, because this group offers unique challenges. And I think that message about not just perfecting HbA1c, but also developing a professional relationship to give a holistic management approach really hit home. So I think we can take some questions. Dr. Karyawasam is live at the moment.
Yeah, hi. Thank you for a very interesting talk. I mean, it was like, it was a very beautiful model which you suggested. I was just wondering that we do have transitional clinics here, but the concept of a young person's clinic is new for me. It is not something which has been practiced here, and establishing a young person's clinic, because already even establishing a transition clinic has been a challenge to bring on the the pediatrician on the same page, because in Pakistan generally the pediatricians basically do not see the patients beyond 12 years of age. There is a very hard line there. So how do you suggest that we should, I mean, how to get started with a young person's clinic, and exactly what should it encompass practically in our setup?
So I think that's a very good question. And you will be surprised if I say even in the UK, there are a lot of centers that do not have dedicated young persons clinics. So it's not a very well established thing even in the UK. So my main message is keep trying, don't give up, because as long as you understand that you need to do it, it's something that's worthwhile fighting for, because we know even here that places where they have dedicated young persons clinic tend to have much better outcome, much less DNA or non-attendance rates. So the question you ask with how do you engage with pediatricians, I mean, building relationships will take a long time. If you've taken the first step of doing a joint clinic for the transition patients with the pediatricians, I think it is going to take time. There's no easy solution. In the young persons clinic, I wouldn't necessarily expect my pediatric colleagues to see older patients. So they wouldn't see patients up to the age of 25. They will only see, because we transition quite early. So we transition at 16. One of the reasons for us was to transition so early was we had quite a lot of teenage pregnancies. So 17, 18 patients coming directly from pediatric clinic to our antenatal clinic. So that's when we thought, no, we have to start transition early on, so we could discuss these important things with young people. So because of that, we have a pediatrician attending the young persons clinic who would see patients up to the age of 19, but not beyond that. So I don't know whether that was what you asked. And what is needed in a dedicated young persons clinic is the things that I discussed before. It's a multidisciplinary team. It's a team that understands how to even communicate with young people. You know, you can't have your standard approach that you have for an adult for your young person service. So there are different factors and different things that I've already sort of discussed in my talk. But yes, I mean, keep trying. You know, as I said, it's not common practice even in the UK.
Zaman, can I ask a question? Right. A very good talk, thought-provoking. My question is, in NHS, is the funding for establishing such clinics by default, or it's the team which comes first and through their passion, they draw these fundings?
So in the NHS, as I said, there's something called the best practice tariff for a pediatric clinic service, which means they get an enhanced payment up until the age of 18. So for every pediatric patient in a hospital will get paid about £2,800 per person, but that's based on SSX, sort of achieving certain targets, i.e. they have to have seen once a month, so they have to have 12 contacts, out of which 4 has to be face-to-face. They have to have, there are certain criteria attached to you getting that tariff. Unfortunately, even in the UK, from the age of 18, you get the standard normal tariff, so a new patient and follow-up tariff. So there's no extra money, and as you're quite right, it's based on how much the clinicians value this service. And we have taken the ethos at Guy's St. Thomas as always, because this is your high-risk population where you can do a difference, and if you get it right at that age, our financial model is you'll stop patients going into renal failure, needing transplant or dialysis, which is very, very costly. So actually investing at this age group where you can make a huge difference in how they're going to look after their diabetes long term will have economic benefits. And there is talk, I don't know how it's going to happen with the pandemic and all the healthcare problems, but there was talk before COVID, actually, this tariff would be extended up to the age of 25. Now it's a bit up in the air at the moment, but there is sort of gradual recognition that this age group needs to be, we have to invest in this age group because they're a high risk group.
Thank you.
Okay, well, thank you very much, Dr. Karyawasam, again for accepting our invitation, for recording, and for joining us live on Saturday. And I just received a text message from Giuseppe. He's sending his warm regards to you. Thank you very much.
Thank you very much.
We wish you a very nice weekend ahead. Thank you. Bye-bye.
Thank you. Good luck. Thank you very much.
Okay, last but not least, our third speaker is respected Professor Zaman Sheikh, who is a professor of medicine and consultant physician specializing in diabetes and endocrinology. He's a fellow of Royal College of Physicians and has masters in endocrinology and diabetes from Glasgow University. He has extensive experience in the management of hypogonadism, and today he will be talking about current knowledge and controversies in testosterone replacement.
My topic today is testosterone replacement therapy, controversy and recent trends. So I will not mention any pathophysiology and what are different types of gonadism, because it was nicely told yesterday by Dr. Richard. So I will focus only on replacement therapy, controversy, and what's the update latest. I will try to finish in 20 minutes because when bell rings, I start feeling palpitation. जैसे किसी के घर में घुस जाते हैं ना, वो घर वाला कहता है नहीं आओ नहीं हम आएंगे, भाई दूसरों का टाइम है, you cannot interfere in others' time. So I will try to finish in 2-3 minutes ज़्यादा हो जाए तो. Okay, so this is conflict about this talk. None. So let us scratch our head. Achha, I tried to see these topics in Google. Google may within 1 second 30,000 result came. 30,000 result 1 second. वो जैसे बेगम साहब से कोई क्वेश्चन पूछो तो आधे में शुरू हो जाती हैं. तो गूगल बाबा भी भाई क्वेश्चन सुनो तो सही आप क्या है. 30,000 इतनी such a common topic. अब ये मसला हो जाता है 30,000 में क्या सिलेक्ट करें क्या सिलेक्ट न करें. तो मैंने बड़ी मेहनत की. देखें ना, छोटे को बड़ा करना आसान होता है, बड़े को छोटा करना बड़ा मुश्किल होता है. मोहम्मद अली जौहर मौलाना से किसी ने पूछा कि भाई आप इतने लंबे लंबे आर्टिकल लिखते हो. उसने कहा भाई इसको छोटा करने का मेरे पास टाइम नहीं है, मेरे दिमाग में जो आता है मैं लिखता जाता हूँ. तो ज्यादा मेहनत करनी पड़ती है, जब ज्यादा डेटा हो कम करना पड़े. बहरहाल आई हैव ट्राइड माय बेस्ट. ओके, डिफाइनिंग द कंट्रोवर्सी. बहुत सारे नाम आए. पहले एक नाम आ गया जनाब मेल मीनोपाज. उनको जिद आ गई औरतों का मीनोपाज है, हमारा भी मीनोपाज होना चाहिए. भैया मर्द हो कैसे हो सकता है मीनोपाज. फ्लशिंग आपको नहीं होती, फ्लशिंग होती नहीं है मर्दों को, मगर ये नाम रख दिया, फिर बड़ी मुश्किल से रोका कि भाई गलत नाम है, इस तरह नहीं। अच्छा, एंड्रोजन डेफिशिएंसी इन एजिंग मेल, फिर एडम आया, एडम आ गया, फिर सोचा कि नहीं भाई ये तो पार्शियल है, टोटल तो नहीं होता, बिल्कुल खत्म तो नहीं होता मर्द आफ्टर सम इयर्स, तो फिर कहा चलो भाई पार्शियल हो गया। फिर आखिर में आया लेट ऑनसेट हाइपोगोनेडिज्म, ये भी मैंने मरोवत किया, बहुत लंबी लिस्ट है इसकी, सो डोंट सी दिस, क्योंकि मैं भी यहाँ नहीं देख सकता, छोटे लफ्ज हैं। So I will try to explain on this. This is famous study of Davis. ये फ्लोरेंस अगर आप गए हो इटली में, वहाँ पे ये माइकल एंजेलो का मास्टरपीस है पड़ा हुआ। And this is typical testosterone filled male. अगर ये है तो कोई टेस्टोस्टेरोन न कराए, ये टेस्टोस्टेरोन लाजमन है इसको। जैसे अकिंथोसिस नाइग्रिकन्स होती है, भाई इंसुलिन रेजिस्टेंस है, क्यों इंसुलिन का टेस्ट कराते हो जब अकिंथोसिस नाइग्रिकन्स है, इस तरह ये मस्कुलर मींस टेस्टोस्टेरोन। यहाँ दिखाने का मकसद ये कि बिसाइड्स जेनिटलिया सेक्स हार्मोन, it has got many other functions, so it is often used or misused for those functions besides sexual function. तो उस पे जरा कमेंट करेंगे कि लेटेस्ट क्या है इसका अप्रूवल। Now conditions. Hypogonadism is classified as primary, secondary and mixed. अब ये ना confirm primary है, primary means LH FSH very high, menopause औरतों में primary है, FSH लाजमन 20, 25, 30 से ऊपर, यहाँ होती नहीं है FSH either normal or low, very rarely it is high. Secondary भी नहीं है, it is not very low, it is actually mixed. After 40 degeneration start होती है। अच्छा देखिए, there is difference some replacement therapy of hormone, पहले एक beautiful एक लेक्चर था मुझसे पहले, फर्स्ट लेक्चर जो इस सेशन का था, कि भाई ये हर हार्मोन रिप्लेस थेरापी जरूरी नहीं है, when it is deficient you do it, hypothyroid please give thyroxine, type 1 diabetes should give insulin, मगर ये it is physiological, it is not pathological, ये age related है, it is not necessary to replace। भाई कुदरत का निजाम है, आफ्टर 40 डिक्लाइन और हर एक ऊपर जाना है, खामखा इंटरफेयर न करें कुदरत से, फिजियोलॉजिकल बैरियर को न तोड़ें, वो लाजमी है कुदरत के लिए। तो एक हद तक कुदरत से इंटरफेयर करना, ये स्टेम सेल थेरापी वगैरह में खिलाफ हूँ, उसकी सही बात बताएं। यू आर आप यू आर डूइंग समथिंग विथ नेचर, नेचर है उसको छेड़ते हैं आप। भाई कार्सिनोजेनिक को स्टेम सेल को आपने कर दिया, 10 साल के बाद कैंसर हो जाए, 5 साल के बाद कैंसर हो जाए, लॉन्ग टर्म स्टडी तो हुई नहीं है, अभी तो शुरुआती खैर नहीं हुई, तो नेचर से ज्यादा छेड़छाड़ सही नहीं है। Although there is no universal laboratory definition of hypogonadism, most laboratory reference ranges for males testosterone less than 300, normal है 300 to 1000. अच्छा, hypogonadism means lesser gonads, either clinical or biochemical. So most of the time these testicular they are reduced in size. So ultrasonography कराते हैं बहुत सारे family physician, it's wrong. अल्ट्रासाउंड कभी भी टेस्ट की सही साइज नहीं बताएगा, टू डायमेंशन है। सो एक्चुअल थिंग इज पेडोमीटर, जो एंडोक्राइनोलॉजिस्ट है उसके पास लाजमन ऑफिस में होना चाहिए। ये clinical hypogonadism is the only FDA approved, this is very important statement, FDA approved clinical hypogonadism is the only FDA approved, एक ही for TRT means testosterone replacement therapy in men. It is not approved to treat age-related low testosterone. आज जो हम बात कर रहे हैं 20 मिनट, वो FDA approved है ही नहीं। Although it is not indicated, testosterone therapy is often recommended to improve sexual function, number 1, bone density, body composition, muscle strength, mood, behavior, and cognition, and some other indication. Use होती हैं off label. The literature on the effectiveness of this on various conditions is largely mixed. कोई एक बात नहीं है उसमें। ओके, रेट्रोस्पेक्टिव कोहॉर्ट, अब ये देखिए ना बहुत सारी स्टडीज हुई हैं, ये इस पे इतना लिटरेचर है कि इसको छांटना मेरे लिए मुश्किल हो गया था, मगर मैंने एक तरतीब से इसको रखा है ताकि समझ में आ जाए। देखिए ये स्टडी है कितनी है, 1990 से 2010, ये 8000 से ज्यादा पर्सन हैं और हाइपोगोनेडिज्म कंफर्म था ये, और लंबी स्टडी 3.4 इयर्स। नाउ ये कंपोजिट एंड पॉइंट ये थे कि टेस्टोस्टेरोन देने के बाद क्या फायदा होता है। अच्छा, इसमें देखिए स्टेटिस्टिकली सिग्निफिकेंट है कि टेस्टोस्टेरोन दोगे तो फायदा होगा, कार्डियोवास्कुलर आउटकम लो रिस्क। तो एक फार्मा ने उसका फायदा उठा लिया। क्या हो गया कि फ्रॉम 2003 टू 2013, ये 2013 याद रखिएगा, ये इसमें फिर चेंज हो गया था सारा सिनेरियो। 4-fold इंक्रीज इन द यूज ऑफ टेस्टोस्टेरोन, 4 गुना ज्यादा बढ़ गया। और इन 2008 टू 2012 4 साल में spending on this increased from $1 billion to $2 billion, डबल हो गया। इतनी कमाई हो गई फार्मा कंपनियों की इन स्टडीज की वजह से। यहाँ पे एक ब्रेक थ्रू आया। In 2013 and early 2014, 2 studies reported association between this therapy, testosterone replacement therapy, and increased occurrence of myocardial infarction and stroke, prompting FDA to issue a safety bulletin on January 30. एक हफ्ते के अंदर FDA ने safety bulletin किया कि कार्डियक सेफ नहीं है। अच्छा, why we are afraid of heart? भाई डायबिटीज में तो पता नहीं कितनी कॉम्प्लिकेशन होती है, ब्लाइंडनेस, किडनी फेल्यूर, एम्पुटेशन, पता नहीं क्या क्या होती है, मगर फोकस हार्ट पे क्यों है? क्योंकि सडन डेथ, आदमी को टाइम नहीं मिलता वसीयत करने का। तो कई ऐसे हैं कि भाई बेगम को का दिल घबरा रहा है, पानी का गिलास लेके आओ, बेगम पानी का गिलास लेके आई और डेट, कार चलाते हुए डेट जनाब, कार यानी पार्क करने का मौका नहीं मिला, सडन डेथ। उसकी वजह से सब परेशान है। एफडीए ने भी बाकी सारे किडनी वगैरह ये सेकेंडरी एंड पॉइंट रखे हैं, प्राइमरी हमेशा हार्ट रखा है बिकॉज ऑफ सडन डेथ। अब ये देखिए ऊपर स्टडी आई नवंबर 2013 में, उसके फौरन बाद एक और स्टडी आई जनवरी 29 में, और दोनों ने कहा कि भाई हार्ट अटैक ज्यादा होते हैं, ये सारी कॉम्प्लिकेशन। और विद इन 1 वीक एफडीए ने एक नोटिफिकेशन निकाल दिया और प्रेस में तहलका मच गया उस 2013-2014। क्या FDA evaluating safety of testosterone product and not good for heart है। अच्छा, FDA ने जनवरी 2014 में रिकमेंड किया कि और डेटा चाहिए, जिस तरह एवेंडिया रोजीग्लूटाजोन के बाद FDA ने कहा कि भाई अब सब कार्डियक सेफ्टी की ट्रायल करो, हाथ पांव बांध के, यानी वो जो 10 साल से ज्यादा डायबिटीज हो, 60 से ज्यादा ऊपर हो एज, और कार्डियक प्रॉब्लम हो चुके हों या रिस्क हो बहुत ज्यादा, वो लोग आए, स्टडी करें, उनमें सेफ्टी प्रूव करो, फिर अमेरिकन मार्केट में माने देंगे दवा। बिल्कुल इस तरह एफडीए ने कहा भाई अब सेफ्टी प्रूव करो उसकी, तो स्टडी शुरू हो गई। फिर इन 2016 to 70 डेटा फाइनली सम क्लियरिटी ऑन दी कंट्रोवर्सी, मगर अभी तक क्वेश्चन है और नॉट। NICH set out to start a pilot study in older men more than 65 years with low testosterone and clinical features, documented थे, और 790 एक स्टडी में एनरोल किए और कंफर्म केसेस, डबल ब्लाइंड प्लेसिबो कंट्रोल और स्टडी थी, और 1 साल की स्टडी थी, 12 महीने। अब ये देखिए उसके बाद धड़ाधड़ स्टडी आई, 7 स्टडी थी टोटल NICH की और रिलेटेड ऑर्गेनाइजेशन, 7 स्टडी। अच्छा, उन सब ने कहा कि सेक्सुअल फंक्शन प्लस फायदा, फिजिकल फंक्शन फायदा, यानी मसल वगैरह, मूड एलिवेशन, वाइटलिटी इक्विवेलेंट, कॉग्निशन फंक्शन इक्विवेलेंट, एनीमिया फायदा, और बोन हेल्थ ऑस्टियोपोरोसिस गुड। कार्डियोवास्कुलर के लिए अभी तक थोड़ा रिजर्वेशन थी, मगर कई स्टडी आई, दिस इज वन ऑफ दोज स्टडी। इन्होंने कहा कि इंक्रीज्ड नॉन कैल्सिफाइड प्लेक वॉल्यूम नोटेड इन टेस्टोस्टेरोन, इंक्रीज्ड नॉन कैल्सिफाइड, मगर साथ साथ ये भी कहा कि डिक्रीज इन कैल्सिफाइड प्लेक। तो ओवरऑल नतीजा ये निकाला कि नो इंक्रीज्ड मेजर कार्डियोवास्कुलर रिस्क इन ईदर ग्रुप। अच्छा, मेटा एनालिसिस, कार्डियोवास्कुलर रिस्क एसोसिएटेड विद टेस्टोस्टेरोन boosting medication, a systemic review meta analysis. There have been at least 16 meta analysis showing no increase in cardiovascular events, so this is reassuring news. अच्छा, अब देखें और इंडिकेशन देखें। Indication and other uses, The testosterone replacement therapy in males with low concentration of testosterone is controversial because the condition is often a normal size, sign of aging. It's a normal physiological phenomena, I already mentioned. Testosterone concentration in men naturally begin to decline at age of 40. 40 peak है, उसके बाद decline है. हमारे Prophet सल्लल्लाहु अलैहि वसल्लम में 40 ईयर में आई थी, आपको इल्म है. In average of 1 to 2 ये नबूवत जो आई थी सल्लल्लाहु अलैहि वसल्लम की. At an average of 1 to 2% per year, clinical hypogonadism, however, an approved indication for testosterone replacement therapy, and is the only FDA approved indication for testosterone replacement therapy. Now, diagnosis. Low testosterone concentration should be confirmed on at least 2 occasions. Just when we diagnose diabetes, it should be 2 times. You make a diagnosis, reconfirm. Likely here 2 times. Okay, associated clinical features, signs and symptoms should be evaluated via questionnaire, valid questionnaire. Confirmatory diagnosis made via total testosterone. ये controversial है, free testosterone, ये वो total testosterone हमारे यहाँ, it's available in Pakistan very much. It is okay if free testosterone is available, preferable. LH and FSH. Circulating testosterone concentration varies throughout the day. So best time is fasting between 8 to 10 a.m. in the morning. So this is one of questionnaire, international. Okay, now this is erectile function, quality of life, separation, very important. Quality of life depends on this thing. So what is the role of testosterone on erectile function? Male sexual function, despite mixed study results regarding increased libido and improved erectile function, testosterone replacement therapy is often prescribed. देते हैं in our setup, family physician give. In a systemic review of 47 studies assessing sexual function, only 23 studies reported beneficial effect. One thing more I tell you, testosterone effects on libido here, hypothalamus, not on ED itself. So sometimes it becomes a problem because libido is more, but performance is less. So it becomes problem rather than benefit. Osteoporosis. Now TRT means testosterone replacement therapy is also used in men with poor bone density, body composition, and muscle strength. A low testosterone concentration reduces bone density and changes body composition. There is no evidence, however, that this therapy decreases fractures. No evidence, no study. So National Osteoporosis Foundation gives no recommendation of this therapy used in patients with osteoporosis. You must have seen estrogen for females, many other treatment therapies, but not testosterone only for osteoporosis men. No, because of these side effects. Now, what is the role on diabetes? Because lack of testosterone means metabolic syndrome. So let us see what is the effect on diabetes. Some small studies has found improvement in HbA1c. A 2019 article stated that testosterone deprivation has been shown to increase the blood glucose concentration, and that glucose concentration improved after replacement therapy. It has been shown. But you see, no international organization recommend this. ADA, American Diabetic Association standards of latest standard of medical care have no suggestions for this therapy. Now let us see risk. What are the risks? In 2015, again, one in 2014, now in 2015, as part of its advisory on cardiovascular risk, FDA issued a safety announcement that, again, repeat, that testosterone replacement therapy is approved only for use in men with low testosterone concentration caused by hypogonadism and should not be used in those age-related low testosterone. In the same communication, FDA strongly cautioned prescribing that this therapy used for other indications, which is off-label. Despite reasonable use for TRT, both on and off-label, questions about risk versus benefit profile remain. Much of the current data shows mixed result. Now, this is Hippocrates, and it said that first do no harm. You may benefit the patient, you may not benefit the patient, but please don't do harm. So we should see these risks before giving testosterone replacement therapy. Development or acceleration of CA prostate carcinoma, BPH, benign prostate hyperplasia, polycythemia, acne, alopecia, gynecomastia, sleep apnea, low urinary tract symptom, liver toxicity, and cardiovascular safety. The greatest concern regarding this therapy involves older men because potential benefit of less clear and risks are greater in this population. Because contraindications exist, it is important to obtain a thorough history and physical examination before starting testosterone. Now, there are some absolute contraindication you cannot give. What are the situation? Polycythemia, CA prostate, PSA more than 4, and nodules upon digital rectal examination. Relative contraindication are hematocrit more than 50, desire for fertility, severe lower urinary tract symptoms, uncontrolled heart failure, and untreated obstructive sleep apnea. Now, secondary exposure, this is important, like passive smoking. Now, this is passive exposure. Testosterone may be transferred to another person following skin contact with the applicable site. So now gel is available in Pakistan, so it can be transferred through skin to other person, and the other partner may get beard after this thing, hirsutism. So be careful. There is a black box warning, especially for children, secondary exposure in children. Monitoring ACE guideline suggests the testing be performed before a patient starts using a testosterone, before basal. Then testosterone concentration be targeted on the mid-normal range, 400 to 700. Minimum is 300, maximum is 1000. A history and physical examination, a total serum testosterone are free. CBC and PSA should be performed at baseline 3 to 6 months after the therapy initiation, and then annually if stable. Conclusion, the literature supporting testosterone replacement therapy is largely mixed and often controversial. However, there are many uses for testosterone replacement therapy, some of them acceptable in carefully selected persons, and others are under debate yet. These are references. Getting old is natural. Feeling old is optional. The trick is growing up without growing old. And the secret to staying young is to live honestly, eat slowly, and lie about your age. Thank you.
Thank you, Zaman. The paper is now open for questions. We expect quite a few questions this time. Sajjad, then Khurshid.
थैंक यू सो मच सर। मेरा क्वेश्चन ये है कि जनरली हम ये कंसिडर करते हैं कि अगर किसी को टेस्टोस्टेरोन रिप्लेस करते हैं दैट वुड इम्पैक्ट द फर्टिलिटी ऑफ द पेशेंट। सर जनरल कन्वेंशनल जो टीचिंग है कि इफ अ कपल इज प्लानिंग फॉर द प्रेगनेंसी या फर्टिलिटी, तो उसमें हम जनरली टेस्टोस्टेरोन रिप्लेसमेंट नहीं देते हैं।
इनफर्टिलिटी के
नहीं देते, तो मेरा एक्सोजेनस टेस्टोस्टेरोन की बात कर रहा हूँ।
Very important question. If you need fertility, please don't give testosterone. Testosterone is essential at some stage of spermatogenesis. Without testosterone, spermatogenesis cannot be initiated and maintained. But if you want fertility, then if you give testosterone in older age group, not in children of late onset thing. In older patient, if you give testosterone, by feedback, it will suppress LH and to some extent FSH. And they will suppress the endogenous release of the testosterone, and spermatogenesis is suppressed. So please don't give testosterone for fertility in adults, never. It will do negative effect.
Sir, मेरा सवाल ये है कि after how many injections or after what duration of therapy it would impact the fertility?
For fertility,
नहीं सर, कितने इंजेक्शंस अगर लगाते हैं किसी को तब जाके इसकी फर्टिलिटी इफेक्ट होगी? सिर्फ एक इंजेक्शन से क्या इनफर्टाइल हो जाएगा?
यार सॉरी आप
थैंक यू सर।
अच्छा जी, देखिए टेस्टोस्टेरोन इतना वो नहीं है डेंजरस कि ये पॉइजन नहीं है कोई स्पर्म के लिए. If you give 2-3 injection, it will not affect the LHFS age. But if you give testosterone in long term as replacement therapy, or for the purpose किसी को समझ में नहीं आया वो fertility के लिए देना चाहता है about 2-3 months, then certainly it will suppress the LH. By the way, मैं एक बात बताऊं कि जो टेस्टोस्टेरोन का फीडबैक होता है वो उसी वक्त स्टार्ट होता है, यानी 2-3 महीने, मगर स्पर्मेटोजेनेसिस के टाइम लेती है ना, तो अगर 1 महीने से ज्यादा दे दिया तो दिस कैन बी वेरी डेंजरस. उस दौरान इतना डेंजर नहीं है, बट नेगेटिव फीडबैक विल सर्टेनली स्टार्ट इफ यू गिव टेस्टोस्टेरोन फॉर. और देन ना, व्हेन फर्टिलिटी इज नीडेड, डोंट गिव टेस्टोस्टेरोन, गिव गोनेडोट्रोफिन. दे आर अवेलेबल इन पाकिस्तान. LH अवेलेबल है, रिकॉम्बिनेंट FSH अवेलेबल है, और you can give, it will take time. और I've seen ये जो testes हैं, size of testes, ये actually grow like a balloon if you give proper dose of LH and recombinant FSH. both are available in Pakistan. 2,500-3,000 रुपये हफ्ते का खर्चा है, और they are available and they may be given for months, maybe years, depending upon the oligospermia, degree of oligospermia and hormone level, and fertility is possible. So don't give, please, testosterone if you are thinking about giving fertility.
खुर्शीद,
अच्छा,
Last
इसमें
question.
एक इसी पे मैं क्या आपसे पूछ लूं कि टेस्टोस्टेरोन देंगे तो टेस्टिस बलून्स की तरह ग्रो करेंगे, कहीं बलून्स की तरह फट तो नहीं जाएंगे? That was joke. अच्छा, मैं क्वेश्चन की तरफ अब आता हूँ.
जी जी, ये एक्चुअली ये मूव ही हम कर सकते हैं.
Okay, coming to my question now. Question is, I saw those levels which you mentioned from ACE. The testosterone level should be maintained somewhere between 400 to 700. Most of the time we see this low T in our patients, maybe in the middle age. Many of them, they're diabetic, they are suffering erectile dysfunction as well. And I would like to ask for your take on this one, because many times what we have seen, instead of, because 400 is quite a high level of testosterone for someone who's maybe in his 50s or so. And then plus that's the same person who is who does have some degree of erectile dysfunction. As a clinician, what I have noticed is if you give these patients phosphodiesterase, even though their testosterone levels is around 250, instead of keep pushing on testosterone, give them some phosphodiesterase. It works very well with maybe lower end of testosterone, boosted their erectile dysfunction, improved with the phosphodiesterase. So it works for many of the patients I have tried, even though I realize that the ACE number, what they're recommending, the absolute testosterone is much higher than that. I would like to, because you treat a lot of hypogonadism, you treat a lot of erectile dysfunction in your practice, I understand. So what is your opinion on this? Keeping, if someone's testosterone is lower end of the normal, keeping it there and trying with phosphodiesterase, because many of them, they have erectile dysfunction of some degree. Thank you.
Khurshid Khan, look, there are two aspects. One is clinical, other is biochemical. No, it depends upon the degree of the clinical features, number one. If clinical features are very prominent, don't rely too much on testosterone. And if testosterone is very low and some clinical features are present and patient is worried, only then you treat. So low testosterone with clinical features, it is significant, and then you replace the testosterone therapy. Otherwise, it can cause more harm rather than causing benefit.
Thank you, Zaman. I think with the time constraint, we will have to have the other question answers in the tea session. And we have to finish off here. It was a very, very good session. Now it's my and Fawad's the responsibility to call it a day. All the speakers were very good. The talks were thought-provoking. Zaman साहब की तो talk हमेशा लोगों को जगा देती है. अगर Zaman साहब मैं बस आखिर में कुछ पूछूं तो ये पूछूंगा कि जो आपने ये मॉन्यूमेंट दिखाते हैं फ्लोरेंस का, जिसमें आप कहते हैं कि इवन आप अगर प्राइवेट्स ना भी देखें तो मस्कुलर बॉडी और मसल्स और उससे पहचान लेंगे कि इसमें काफ़ी टेस्टोस्टेरोन है, तो उसमें आप बेड क्यों नहीं दिखाते? बस ये मेरा सवाल है आपसे. Sorry about this, but it's like. Thank you यार, मेरा सवाल था ये. कोई और वजह तो नहीं है ना? Thank you. We finish it off here on this happy note, and yes.
Thank you very much, Professor Abdul Basit. I would like to request Professor Najim to kindly come on the stage and present certificates of appreciation to the chair. Thank you. Dr. Fawad. Dr. Fawad Rhandawa, thank you very much. And Professor Abdul Basit, please, if you could come. Thank you.